Hello, good evening, ladies and gentlemen. If I can start the meeting. Firstly, we have apologies. I believe it's only Beth Rowlands who sends her apologies tonight. That's why I'm unfortunately chairing. In terms of minutes of the previous meeting, we have two sets of minutes from the previous meeting, held on the 8th of July and the 27th of August. Committee members, by a show of hands, indicate if they accept the minutes, please. Do you accept the minutes? Yes, 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 super. Thank you, that's confirmed. Are there any declarations of interest? No. We have a public question, which is wonderful. Good to see a public question. So, yes. Do I have to read the question as well?
So ask Anna to ask the question.
Yeah, okay. So, Anna Overd has asked the chairman of the Health Overview Scrutiny Committee the following question. Would you like to speak, please?
I could speak instead of Anna because she wrote the question for me because I was on holiday.
Could you just bring the microphone?
I absolutely can, although I'm quite loud generally. But So I'm Debbie Morrison. I'm the CEO of CLASP, which is a charity that supports adults with learning disabilities. And for the last 6 years, I'd say we've been campaigning to try and get rid of health inequalities, and with marginal success. So our question is, what steps are Woking Borough Council taking to encourage GP practices in our borough to appoint learning disability leads? According to the 2023 Leader report that was only published in September 25, adults with learning disabilities die on average around 20 years earlier than the general population, and nearly 39% of these deaths are avoidable. That's almost double the rate of the wider population. The report highlights persistent health inequalities, especially in minority groups, for instance, Asian and Asian Black backgrounds, who have a significantly lower age of death. Having a named LD lead, even non-clinical, can help ensure people with learning disabilities are identified, given the appropriate reasonable adjustments, invited to annual health checks and afforded tailored care. Could the Council please outline what strategies, partnerships or guidance are being promoted to GP practices locally to support this, and how progress can be monitored? And thank you for listening to our question.
Thank you very much for your question. I believe you're going to get a written response, but I'm also going to read the response that will be provided to you. So let me start. Please accept our sympathies and acknowledgement for the health inequalities that people with a learning disability experience. This is a national issue, and we share your frustrations and ambitions to do more. In the Berkshire West Health and Wellbeing Strategy, Priority 2 commits to support individuals at high risk of bad health outcomes to live healthy lives. In the Woking Health and Wellbeing Board Strategy into Action, under Priority 2, we have explicitly identified people with a learning disability as a priority group for action, and work is being taken forward through the Learning Disability Partnership Board. Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, ICB, commissioned GPs in Woking. They have confirmed that whilst there is no contractual requirement for GP practices to have a lead for learning disability, this is good practice. That the ICB's Clinical Lead for Mental Health and Learning Disability has always encouraged such roles. Whether clinical or non-clinical, leads work to, I'm not sure that's correct, leads work to improve access to care for learning disability patients and to increase uptake of health checks. Uptake of learning disability health checks has been a key focus in recent years and is regularly monitored through NHSE regional and ICB local performance and quality dashboards. In 2024-25, the overall uptake rate for Woking GP practices was 69%, compared to Berkshire West average of 74.5%, with uptake by primary care network ranging from 56 to 77%. Uptake of health checks is discussed with practices through the ICB's practice visit programme. The recent CQC report recognises our efforts to support people with learning disabilities through the Learning Disabilities Partnership Board, which are well established, supporting the Woking Health and Wellbeing Strategy into Action Steering Group. The local authority was strongly connected into partnership arrangements through these groups as a key contributor, alongside health and voluntary and community sector partners, as well as people with lived experience of services. The groups facilitated and oversaw joint partnership activity to deliver outcomes against the borough's health and wellbeing strategy into action. The Learning Disability Partnership Board has 3 priority areas. Number 1, supporting people with learning disability into employment, 21.1%, but a gender gap requires further work to improve employment for women, 17.3% versus 23.2% for males. Secondly, supporting people with learning disability to live in stable and appropriate accommodation. 91% live in their own home, but again, lower for women, 88% versus 91% for males. Thirdly, people with a learning disability who had a health check and an action plan completed within the last 12 months is rated at 73%. Woking Borough Council support people with learning disability as best as we possibly can, given the funding made available. This year we have a budget of circa 28.7 million to support our learning disability community. In addition, we fund the voluntary sector circa 2.4 million to support local people, including those with a learning disability, when other councils have cut this prevention spend. We acknowledge that more can be done and remain committed to finding new ways of improving the health of people with learning disabilities and also reducing inequalities. That's a pretty thorough answer. I hope it helps.
The only reason it doesn't help is actually I am the chair of the Learning Disability Partnership Board, so I know absolutely what we're trying to do to achieve health inequalities, and it's impossible at our level to do that. We need somebody higher up the food chain that actually can knock on those doors and make something happen. And whilst I appreciate the answer and the effort that's gone into the answer, the 73% of people that have an annual health check do not have it with a doctor. They often have it over the phone. They often don't have a health action plan, and there's nothing done to measure the quality of the annual health check. And lots of people get ticked as having an annual health check when they actually haven't turned up because their care isn't there. So actually, whilst it's a very nice, good, long answer, I think it's a really politically correct answer as opposed to actually addressing the problem that we have. And that I don't wish to be negative, and I really appreciate the fact that you've given us the airtime here. But we've, like I say, we as the Learning Disability Partnership Board and individually as CLASP have been at this for over 6 years, and we've spent an enormous amount of money trying to break down barriers that we've raised ourselves, not our council funding, to try and break down those barriers and to get into the healthcare system, to get our voices heard. And I suppose our plea is to have somebody around this table or within the ICB or Bob or wherever it takes to actually help us with that endeavour. We're happy to do the work, we're happy to do all the legwork, but somebody's got to take the initiative to kick the door down and start the process.
May I suggest that when this meeting's finished, we have a chat and link up? You know, I don't want to just drop this.
I wasn't being disrespectful in any way. I am grateful to be at this meeting, but at the same time, I am very passionate about what we do, and we have supported people that have died young through preventable illnesses, constipation, you know, and we do everything we can to raise awareness and do work around it. But actually, at the end of the day, if they can't get a doctor's appointment and they can't get there, then, you know, they haven't got a hope in health's chance. And that is really, really sad reflection on us and the GP service. And actually, if they had an LD lead, the missed appointments wouldn't happen, and it would be a very positive, self-perpetuating cycle. Thank you.
Again, I would like to say thank you for raising this very important question, and we'll have a chat afterwards. Thank you very much. Okay. You've got to speak up. Sorry, I'm deaf. Right, what's the next item? Sorry. Oh, town and parish question time. Were there any town and parish questions? Councillor question time. Any councillor questions? Next item is a Berkshire Coroner's Service. I believe Matthew should be guiding us through his presentation. Or the assumption in this committee, if I can kind of cut to the chase, Matthew, is that we assume that all the councillors have read your report. Okay. And if you can just, you know, sort of pick out a few highlights, important topics, things that, you know, we should really take note of, and then we'll move straight into questions, if that's okay with you.
Fine with me. Sorry.
Thank you.
Thanks very much. Yeah, just to introduce myself, I'm Matt Gollidge. I'm the Acting Assistant Director for Planning, Transport and Public Protection, and Coroners is part of my remit. And this is Rhiannon Charnock. She's the Coroners Team Manager as well, so she's the local expert, I would say, on the Coroner Service, so she will be answering some questions, I'm sure, with some of the details. So, yeah, with regards to the report, I think we've provided some statistics about where Berkshire sits in the sort of within England and Wales and the national averages, and generally we're at a sort of a steady state on that. We're in line with most aspects of those key outputs. One area I know that's been raised before by this committee is around CT scanning, and that's something that we're going to get on to talk about, and Rhiannon's going to contribute to that one as well, about what we're looking to do locally on that. But you'll see that on the figures there's a bit of a difference there between Berkshire and the national average, and there's less non-invasive PMs. I think that's how we would describe it, probably. But this is something that we're looking to grow locally, and we can provide some more details on that at the moment, in a moment. Just flicking through the slides. The major expenditure areas are similar to as they were before. We've got contracts with mortuaries at Reading and Slough, and that's a significant cost to the service area, and remains to be. But we are, again, as part of the options we're looking at, CT scanning. There's opportunities there that we can look at locally, which might change the arrangements we have with the mortuaries and what they actually provide. So we can come on to that in a minute. There have been a number of service developments that we've initiated over recent times, over the last year. One of those is the bringing the coroner's removals in-house, which is the service which actually collects the deceased from the community. and that's a major change for the service. It enables us to manage that budget area, also ensure that we provide a really dignified service throughout Berkshire as well, and it has provided savings. As part of that, that has provided opportunities to look at other services that we could provide locally that move outside the remit of the coroner's service a little bit, but also has the potential to benefit families throughout Berkshire. So I think what I'll do is I'll pass over to Rhiannon, and she might be able to just go through those new service improvement areas in a bit more detail.
Hello, everyone. Yes, so I'll start off with the CT scanning, which will sort of nicely lead into the other opportunities. So as Matt pointed out, in Berkshire, we don't have invasive post-mortem facilities. So at the moment, we're very much reliant on other areas and other hospitals, which can come at a cost to family members who want that service. So what we're doing is we have identified a very potential site within Reading Borough Council's portfolio that we are hoping to place both a body storage facility and a CT scanning facility within that building, with the view to still using our hospital mortuaries as the first sort of point of receipt for the deceased, and then if the decision's made that they're suitable for a scan, they'll be transferred to this facility where the scan will take place, and there they will remain until they are released until their funeral directors. With the mortuary storage facility and the fact that we've got our sort of collection team in-house, we are also looking at diversifying, and one thing that we've already begun within Reading Borough Council itself is to start to assist with the public health funerals. Now, those are the funerals where there may be no family members or no funds for a funeral to take place. So at the moment, what we're doing with Reading is we're helping facilitate the house search. We're sort of taking the burden and staff time from the team that does that, that had been doing that. And then also we are just trialling actually carrying out the funeral ourselves, rather than the council having to outsource this to funeral directors, which can be quite costly. And this is something that we're hoping to be able to offer to the other jurisdictions within Berkshire, as a way to use our team and also help bring down costs for the service for other areas. And sort of drawing on from that, because we will have the body storage facility, what we're hoping to do is then start to be able to offer direct cremations out, not just for public health funerals, but also to residents who wish to take up that service. And that fee will then offset sort of the coroner's service budget, as we'll effectively be using our staff and the mortuary storage facilities. And that, again, will be hopefully offered out not only within Reading Borough, but also as a Berkshire-wide service.
Yeah, thanks, Rhiannon. So yeah, I mean that's where we are really at this stage, and so happy to take any questions.
Super, thank you very much. Questions, anyone? Mike?
Just reading the stats.
Microphone, Mike. Sorry. Stick it under your nose, please.
Just looking at the stats, which I know nothing about, the activities really that go on here. We have about 18% of the population of the whole of Berkshire, and we have about 18% of the deaths. But we don't seem to be making quite as much use of your services as presumably other boroughs are. Is there any particular reason for that? Are we
I think we wanted to just demonstrate, just show the Wokingham figures for last year. We haven't done any sort of trends over any longer than that, so we just wanted to give a proportion, but you know, I don't think there's necessarily anything in it to suggest that there's any difference in the areas, and that can fluctuate as well.
I can possibly add to that as well, is that these the sort of total deaths are actually recorded at place of death rather than place of residence. So because we've got Royal Berkshire Hospital in Reading and Wexham Park in Slough, then perhaps, more Wokingham residents, do pass away in the hospitals, but it's not being reflected in the figures due to that reason.
Thank you. The other question I have was actually about the CT scanning. I was just wondering, compared with an invasive post-mortem, how much can you actually determine in a CT scan? Is it exactly the same information?
More or less. So the national figures at the moment from jurisdictions that have been sort of way ahead of the curve with invasive scanning is that about between 75 to 80% of deaths can be diagnosed at CT post-mortem. So it's actually quite a large amount, and that's only ever increasing with the sort of expertise as it develops, with other sort of minimally invasive techniques being used with the CT scanning, such as angiography, which is sort of a dye pumped around the heart, which makes it show up. So it's a very good high proportion that can be found out at CT scan.
Alison Swaddle, please. Sorry, I thought you put your hand up.
Okay, we did answer one of my questions when you explained that the place of death being hospitals will really skew numbers, because I was looking at the fact that we pay 20% of the cost, and how often for many of the services we're using a very low level of those. I'd just like to really refer back to the last time. I'm so sorry, Matthew, but I can't remember if you came to us when we first looked at the coroner service. And I think there was a mention that it's quite hard to recruit pathologists. And I just wondered if that had changed or it had worsened.
So the coroner service, and we don't directly recruit pathologists. They're sort of employed in contractual basis individually, and they're very few and far between, and it's a national problem. The pathologists are normally employed full-time by the NHS trusts. So at the moment, we've got 2 pathologists that carry out post-mortems in Reading, and they're employed full-time, and they do this work outside of that. And then at the other hospital, we've got 1. And then we have some that we can use, and that's via agencies, which is obviously quite expensive. But years ago, when you studied pathology, histopathology, doing coroner's work was a mandatory part of that course, and it's now not. So many pathologists are coming through the system having not been trained and not able to do coroner's post-mortems. Additionally, the national fees, guidance fees, pay for pathology has not been changed since 2013, perhaps before that. So whilst we have local arrangements now with pathologists, which is the same nationally, the government are still yet to review those fees, and that's what's putting quite a lot of them off from doing the work, as well as the NHS trusts not giving them enough time to do the work on the side that they need to do.
So if anything, it's got worse because you're having to pay a higher rate.
Yeah. It has, absolutely. And that's just not a local thing, that's a national thing, unfortunately.
Rochelle, please.
About 1/6 of the total deaths in Wokingham are reported to the coroner. What determines that it goes to the coroner? Is it suspicious deaths? Is it something unusual? Is it...
So deaths need to be referred to the coroner if cause of death is unknown, okay, or unnatural in any way. So unknown could be that it is still a medical cause of death, but there's not a practitioner or an attending practitioner who's ever seen that patient in life who could sort of give that cause of death in their best knowledge and belief. And then unnatural causes can range from anything to an elderly person having a fall and breaking their hip and dying of pneumonia in hospital, right through to road traffic accidents, suicides, and that sort of thing.
Any further questions from anyone? Melanie? No. I'd like to make a few comments and a few questions, if that's okay. I think overall this is a very encouraging report. Thank you for this report. It's good to see that you're taking what look to be very sensible service and financial steps to, I would say, optimise the value for money for Berkshire. I think that's really good. A small question. On here we have non-invasive on page, sorry, I'm not sure what page it is, but it says Wokingham, non-invasive as 0 out of 83 post-mortems. And when I look at the graph, 2 pages further on, there is a value for Wokingham. If it's 0, what's that value?
I can explain that. So with non-invasive, the category at the moment, which we take from the Ministry of Justice statistical report that we have to produce, non-invasive includes also external only examination, which is not a CT, it's where the pathologist just looks externally at a deceased and gives the cause of death, which is done in mostly suicide cases, where it's quite obvious what they've passed away from. The figures for Wokingham is that there's been non-invasive CT scanning, but you've still had some external only examinations, which is represented on that graph slide.
Right, I got it. I've got you. And you know, if back on the CT scanning thing, last time we talked about this, I mean, I think we were essentially saying that you didn't have access to enough CT scanning facilities, whether that be Royal Berks or Wexham or wherever, that there was a supply constraint to you as a service from NHS trusts. Is that still the case?
Well, I think so. At the Royal Berkshire Hospital and Wexham Park Hospital, there is not the facilities to use CT scanning for deceased persons. We have occasionally used their facilities, but it does involve using it out of hours when obviously there's no live patients going through. So it's not a sustainable service to keep it at the hospitals. And if we did, it would sort of be a bit of a bolt-on to, and neither NHS Trust sort of were able to provide sort of interest in that at this stage. However, what it's hoped is we're hoping to have this facility, and we're going to be putting out a soft market testing exercise towards the end of the year, which will be going out to all sort of providers.
Or a request for tender or something?
Yeah, just an initial sort of marketing thing to see if they would be interested in coming and running a facility, what that would look like. For example, post-mortem rates in Berkshire are actually quite low compared with other jurisdictions. So one such company I've spoken to says, well, we possibly don't need one there permanently. We could come in with a mobile once or twice a week, which would again bring costs down enormously. So that's the sort of things that we're looking at the moment.
One of the questions that we didn't satisfactorily bottom out last time was really around charging the family for non-invasive post-mortems, especially where there is a religious context. So I kind of, what's the service's view on going back to families and saying, well, if you want to have this special non-invasive post-mortem, you'll have to pay for it. Is that happening today? Are you still doing that?
Unfortunately so, yes. So at the moment, as we don't have the facilities within Berkshire to do that service, if a family does request a non-invasive for purposes of their own sort of desire for faith reasons and other reasons, then we do have to go to facilities elsewhere, which are run by private companies, who then do charge the family. And that decision's made because it's the families, and it sounds awful, the families wish to have that non-invasive, where actually we could do an invasive with the facilities that we have at the moment. So that's been the general consensus in areas where they don't own their own CT scanner. Now, we wouldn't be doing that model if we had the facilities ourselves, as the model would change to a predominantly
I understand where you want to get to, but I'm talking about the brass tacks of what's happening on the street today, and it's one of the questions that we were raising internally through to the leadership team in WBC was, you know, what would be the cost to Wokingham or the whole of Berkshire or whatever for all of these non-invasive post-mortems where the family paid? Would you have the numbers?
Yeah.
Would you be able to provide those in a written answer?
Yes, I would, yeah.
If you could provide us those figures, then we can go back to the leadership and say, if you want to cover this function by not charging the families, which I find very difficult. That sticks in my throat, really. You know, I can't imagine the situation they're in. Those figures would be extremely helpful, and we can push this up the command chain and see what happens.
Yeah.
Yeah, and I think there'd have to be some criteria, because obviously there's a cost to invasive post-mortems that if you subsidised non-invasive post-mortems as such, then they could increase, and the cost of that.
What I'm asking for here is only the charges that have been levied on the family.
Yeah.
Whether that's invasive, non-invasive, whatever it is, any charge to the family, rather than something that's covered by your service.
Yeah.
And if you've got those figures, then that will help me enormously. Thank you. Yes, of course, please.
So, of the 36 non-invasive post-mortems, were they all paid for by families?
Some of them would be, but some of them include the external only, which is something that we deal with in-house. That's part of our normal fee.
Rochelle, please.
Have all of the investigations, either the CT or otherwise invasive, has it saved lives in the process? In other words, they found a problem that was causing these people to die, would also help hurt other people.
With postmortems in general, yes. So on one of the slides, which is around prevention of future deaths, so the 2008-9 Act gave coroners the powers to issue what's called a prevention of future deaths report. So that's when there's been an inquest, or on the lead up to an inquest, where coroners identified that something could have prevented, some agency or organisation or system could have prevented that person from passing away. And it gives them the power to then write to those organisations or individuals to recommend on changes that could be made in the future to prevent deaths like that from happening again. Now, sadly, whilst it's a power to issue that report, it's not legal for the people or individuals or organisations to actually do it.
How much would it cost if all the authorities in Berkshire paid for the services? How much would that cost each of the individual boroughs?
I'm not sure I follow, sorry.
How much would it cost if we did do all of the things and shared it out between all of the authorities in Berkshire? In other words, what would we wind up? What would Wokingham Borough have to pay? What would Slough have to pay? What would somebody else have to pay for this? Just to get an idea, because if we're talking about £10,000, that's different. If it's talking £100,000, that makes things a little bit less likely.
Are you talking about non-invasive post-mortem still?
Yes.
Right, okay. Well, there's 830 post-mortems, and a cost of a non-invasive is
About 550.
£550.
So 550 times 830 it winds up, how much will each of the authorities have to pay to contribute to that? I'm assuming this is not just Wokingham, this is doing this. I'm assuming the rest of the authorities in Berkshire are doing it as well.
I think if I can't add to this
Yeah.
conversation. Sorry, if I can add to this conversation, I think it's just the element where the family's paying.
Yeah.
Because there's already a significant budget from WBC and Reading and everything else. So it's just that differential that we want to really understand. I don't think the question is any more complicated than that. Okay. And when we've got when we've got the numbers, we can then go to our leadership and say, look, it's going to be £5,000 or it's going to be $500,000 or whatever it is.
Yeah.
You know.
Just come back on the one point. There's 6 local authorities in Berkshire, and you all contribute on a pot-based basis, which is part population and part council tax banding. So that's how the budget is split. So it is fairly even across the 6 authorities.
Any further questions?
There's only 5. Oh. There are 5 authorities, aren't there? No. Oh, I see, plus Reading, yeah. I know, I was thinking that was odd. So there's 6 of them, but we're paying 20% in Wokingham. How is that calculated?
It's calculated on a pot-based approach, so it is done on population and council tax banding. So they take into account the number of, different properties in different council tax bandings. It's a sort of a financial, recognised way of apportioning budgets. So yeah, it is the seen as the fairest way of doing it. So because populations, although they're relatively spread across Berkshire, they do differ. So there's going to be slight variations there.
Okay, any more questions, Mike?
If I could just add to that, I used to be part of the Fire Authority, which shares its costs around the 6 different unitary authorities, and the same thing happens there. Wokingham's got a higher population than pretty much all the others, just certainly much higher than Royal Borough of Windsor, Maidenhead and Bracknell. So I guess it comes out of that, because I did the same thing. 20% of the costs, we're actually only using it about 10% of the services.
Thanks for that. Thank you, Matthew. Thank you, Rhiannon. Very, very useful. We would definitely like to invite you back, if that's okay. And hopefully we can hear about some progress with, service development and CTS scanning and everything else. But thank you very much for your time. Really appreciate that. Thank you. What's the next item, Madeline? Have we got the Wes show? Ophthalis. Oh, sorry. Helen, welcome again.
Hiya.
And are you going to be talking as well, Wes? Or?
Yeah, I'll be supporting Helen. Yeah.
Okay, super. Well, I'll hand it over to you, Helen. Again, the assumption is if we've had a report, then we've looked at it. So maybe if you could just give us a quick, these are the really important pieces, then we'll move to questions, if that's okay with you.
Yeah, that's fine. I wasn't given much of a brief about the presentation, so I just did put some information together, but happy to expand on anything anybody wants to know. I guess in this presentation, one of the key things is the visual map of all the services that we support. I think it's quite good to see the breadth of services within Wokingham and the Royal Borough that we support. It's pretty even spread. Lots of independent living services, 3 care homes, two new to us, day services, etc., extra care. So it just shows you the breadth of that. 7 of our services are regulated with CQC, and 4 of them are rated good, and 3 have yet to be inspected. So I think that also demonstrates that the quality of the support that we deliver to people across the borough. I've provided some highlights around how many people we employ. Across the organisation, there's 900 people, and circa 900 people in Wokingham that we support. And that's across all of the services, whether they're extra care or whether they're in our care homes. We've had quite a lot of growth recently. We've had 2 new care homes in the last couple of years. One lately in February this year, the latest home joined us, that's the Hollies, and supported 4 new supported living properties came to us recently as well. So we've had quite a lot of growth, and that takes quite a lot of resource and effort to land safely and to support people safely. So we're really proud of that. With the Bluebell and the Hollies are care homes with nursing, and that was new to our portfolio. We hadn't managed nursing homes before, so that's been a huge learning curve for us. But Bluebell, that we've had for 2 years now, is a real success story. There's been a huge refurb of that property, and we've been able to improve the quality of the care and the support that people receive there. And even if I say so myself, it's a good place for people to be and live, and the quality of the care is good. We are, like I say, Holly's transferred to us in February, and we are now doing the same with the Hollies. There's a refurbishment plan, and we're doing a lot of work to improve the quality of the care and the support that people receive there. With both Bluebell and the Hollies, we 2P'd the workforce across to ourselves, so we're having to work with other providers that had different standards, and so there's been a lot of work in bringing the standards up to Optalis standards. I think as well you can see some lovely compliments there. I think that's really good for people to see what people think of our services generally on the whole, so that's good to see. And I think our focus at the moment is on the Hollies and turning that around, whilst also in conversation with working about other services that they want to give us. So still some growth on the horizon for us.
Thank you very much, Helen. Wes, do you want to top and tail anything, or is that?
I think from an adult social care department and as the lead commissioner, I think what Optalis have provided Wokingham Borough Council in recent years is that strength of that strategic partnership and being really able to address service needs within the community with a partner really focused on a high quality care. And I think, as Helen said, Bluebell's real evidence of working together, how we can improve outcomes for the local community.
Thanks, Wes. We'll move to questions. Rebecca, please go ahead.
Thank you, Adrian. I was interested in looking about the CQC inspections for Bluebell. So I'm right to understand that hasn't been inspected since you've taken it over. So if that hasn't happened, so how are you monitoring the progress that you're making in turning that round? And the other thing was Hollies. This is where it makes you think, how good is CQC when it's got areas that were good to outstanding, yet you've taken it over and said that you need to turn it around. It doesn't quite make sense, but I'm sure you can explain.
Yeah, I'll try. Bluebell, we put a framework around the governance of what's happening at Bluebell. So initially we had to understand what wasn't working and what needed to improve. And so we had a robust action plan and worked through those areas. Largely both with Bluebell and Hollies, the quality of the support plans was poor, and that needed improving. So that was kind of one of the key areas we had to work on. We employed a specialist to help us turn that around, to improve the quality. Given that we hadn't managed nursing homes before, it was an area that we needed some specialist support in. So we got someone to help us with that, which she did, and she's also back now helping us with the Hollies, so we can hopefully mirror what happened at Bluebell in the Hollies. We do continuous auditing. We've strengthened our own quality team, so we've increased the numbers. There's lots of auditing that happens there. Wokinham's quality care team, they come in, they audit us, and they've done that, and they've seen and said how good our support plans are compared to what they were before. And they are a hard act to please, the care quality team in Wokingham. So I think we feel reassured that what we're doing there is working. And it is working because the quality of the support people receive and the compliments and the relatives, the families, the customers, the residents themselves, tell us. We seek the feedback, so we get that. As far as a CQC are concerned, they, when you take on a new service, they should inspect you within 2 years of taking that service on. So we are at that point now, and we know the inspectors are in the area, so we are expecting them to descend on us at any point. And although you never know what they will find and see, and we feel we are ready for their inspection at Bluebell. The Hollies, yeah, you're right. It came across. So you inherit the ratings when the service is transferred to us. You inherit their rating. Bluebell was poor, requires inadequate, and the Hollies was rated good with 2 areas of outstanding. Yeah, have no idea how that happened, because that's not what we found. But their inspection was also, I think, a couple of years old, so it's out of date. When it comes to us, it's out of date. So if they were to come now, we've still got quite a journey to make to turn that around. We're not there yet, and it took us the best part of 18 months to turn Bluebell around. So we anticipate the same amount of time for the Hollies too. But it's a similar journey. Less of a refurbishment plan. Didn't need as much work on the building as Bluebell, but the care and everything to do with the care needs to be turned around. If you want to.
I guess just to add on the quality assurance aspects, as Helen said, we have a quality assurance team that complete their assessment of all local provision around the duty of care providers within the borough, and that process has been undertaken again with that relationship with Optilis in a very constructive manner. So we have seen from the quality assurance process, the difference is phenomenal in terms of when it was before and now in terms of Bluebell. And I guess just the other thing is, when this is a softer thing, I guess, if you went to the Berkshire prior to us purchasing it, you could tell culturally there was a quiet ambience in the building. There was a few people there. It was very, people stayed in their rooms. I think what you see now when you go into Bluebell House is very different. It's full. People want to be in the communal areas, they want to engage, and there is a fundamental change in culture at the home.
Rochelle, please.
Can we roll out what we've learned in Bluebell House to other properties that we may buy in the future, and also or we can help to reduce our costs, period, and to improve the environment for the people in the homes?
Just on the first point, the prospect of purchasing another home is very, very small. In terms of the number of homes in the borough, the size, the generations, there's a lot of old houses that have been converted. So to be honest, the possibility of us buying another home is quite small in the local area. We have the same care quality team that support all care homes in the borough, and that obviously goes in terms of health services and the support that they receive there. What we've learned from just the refurbishment aspect in the Hollies is that around being dementia friendly, and a lot of what you'll see in the Hollies from a fabric sort of sense we are replicating in the Hollies, and you will see the same colour paints, the differentiating between wings, etc., and we'll learn from that being that dementia friendly.
Will we share this with some of the other sites not owned by Woking Borough to say that this is what we've done that saved money and increased everything for the local residents in the home? Can we roll this out to other places? In other words, that are not owned by Woking Borough, but suggestions that we found that this works, that works, the other thing works. So you have successes and help have other facilities also have those same kind of successes. We can't control them, but we can tell them what we've done that works.
I mean, that's something that, you know, we could look to do in the future. I think we need to be entirely proficient at what we're doing in our nursing homes before we would feel confident to roll that out to anybody else. I mean, it's been a journey for sure, and lots of learning curves for us.
And that journey continues with the Hollies, I guess, as well, in terms of our prioritisation.
I think it's Mike next.
Thank you. I've got a couple of questions on slide 7. You employ 902 staff, but then presumably a fair proportion of those are involved in looking after people in the Maidenhead.
Yes, sorry. Yeah, that's our entire workforce. Yeah.
Okay. And you recruited 159 people. What I was interested in is the churn rate. So does that infer you've lost 159 people as well, or is you expanding?
Yeah. So our churn is lower than the national average. So it's about running at about 21%. But we've recruited, like I say, 159 people. But then we're getting more services, so we need to recruit more people. The nursing homes require a lot of staff, and neither came across to us with as many staff as it needs to support the needs of the residents that live there. So there's been a lot of recruitment activity for the care homes per se. So yeah, and the more we grow, we had 4 new independent living services. People are coming to us with quite high needs, and we need to recruit more staff. So.
The sort of follow-on question from
Can
that.
I just add something to that? And that is, you've also helped reduce the number of agency workers you have to use, and that's very positive as to cost and also consistency for the people who use their service.
Yeah, for sure, David. We do use agency. We at times have to use agency to ensure we provide safe care, but we don't want to use agency. We absolutely want to employ 100% of our own workforce. Consistency for sure, level of training, everything, the care that people can receive, it's better if they're employed by us rather than our agency workers. So, yeah, but we're always chipping away at those agency stats.
And the sort of follow-on question was that the last bullet point on that page is that you've seen huge growth over the last 2 years. I was just wondering where that increase has come. Is it because you're now operating care homes, or is it more people being looked after in their own homes, or?
A lot of it is the nursing homes and the independent living services, which are smaller properties where 3 or 4 people might live. So we've had quite a lot of growth in that area. We don't provide dom care as such, so we don't support people on a dom care basis. But I guess if you're living in your own home, it is a bit like dom care, but people are there on site the whole time. So that's where a lot of our growth has been.
Thank you. So Adrian spoke earlier about people living in their own home, and 91.7% of people with a learning disability are living in their own home. And we previously talked here about our specialist accommodation programme, about how we work with our property colleagues to acquire properties, to support people to live in their own home and become more as independent as possible. Often we work with optimists who are providing that care. So that's where some of the areas of growth would come as well.
I think it was Alison next, I think.
Thank you. Thank you very much for coming in person. We do appreciate that. Looking at the map on page 5, we've got 4 residential nursing care homes, 2 in Woking, 1 in Early, and 1, which I hadn't realised, in West Berkshire. But I think Wes had spoken about the difficulties of finding appropriate care homes to purchase, because building one from scratch, as I think we know from experience of trying to do that, is extremely difficult. So of the 116 people in the 4 care homes, what proportion of them are from Woking residents, and what proportion are Windsor and Maidenhead?
I'll cover the West Berkshire question and then hand over to Helen. So the care home, the Hollies care home we purchased in February, is in Burford Common. So it's just so it's just and that relates to the availability of existing stock that's available for sale. Yeah.
So the 56 beds in the Hollies, currently we have 30 people residing there. It wasn't full when we took it over. There's 30 people there, and of those 30 people, there's not many currently Woking residents living there. A majority of people that were there were from West Berks or I think a couple of other odd people from other areas. But the intention, when the refurb has happened, that those beds, the vacant beds, will become available to Woking people, and then as the other people turn round for whatever reason, if they move on, then all of the beds will become available to Woking residents.
What I actually asked about was the proportion of Woking against Windsor and Maidenhead, our partners in Optalis.
So
of the total 116 figure.
Yeah, that is Woking. That's Woking residents at the moment. That's where. Yes, the home in Royal Borough is in Maidenhead, and that's for people with learning disabilities. Homeside and Winston.
Yes, there wasn't a green flag in the Royal Borough, was there, for older people's residential nursing care? So if older people in the Royal Borough need a bed in a nursing care, they would come to one in Woking or Early?
Yes, they would.
Nagy next, please.
I have a question on the Disability Centre moving from Westmead to Matthew Greens, which we discussed in the last HOSC. So I heard the Reading rep have pulled out from managing the community centre. So what's the plan around it? Yeah.
So the plan in terms of the move, that goes ahead, and that will be managed by our property services in the short term.
Any further questions from anyone? Yeah. Go ahead, Mike.
So it was actually a follow-on from something you said a minute ago, which perhaps isn't necessarily directly to do with Optalis. So in Early we had two experiences where properties are being used to house people. One is semi-detached, and it's causing a lot of grief to the neighbour next door. The other one is in a residential area, and it's causing a lot of grief to the residents, apparently, but I'm not sure that's correct. So do you have criteria when you're looking for properties to acquire, to put people into, that looks at the if necessary, the isolation, so to speak, from other properties?
So in terms of our strategic direction, it's about creating a community where everyone belongs, and creating the right home for the right person, so that they can call that home their own. I think that is our strategic direction. It will be based on the needs of the individual in terms of the decision around where someone lives, and the dynamics of the individuals who live in the home. So it could be multiple layer. I think in terms of, Mike, I'm happy to take the individual, I obviously can't speak about the individual cases, but we are working in an environment where other providers of care will obviously be working out in the Wokingham area as well. So there's multiple factors in terms of both where we choose to support people and other people's ability to create supported living within the area.
The two examples, I believe both properties have been operated not by Optalis or anything to do with Wokingham in terms of residents. 9 Sevenoaks Road, which is being converted to make use of, because it's been empty for about 3 years, would be another example. That is Wokingham one, I guess.
Anyone for any more? No? Okay, the next item is Health Watch. I believe Alice is not there yet. Thank you very much. Thanks. I believe Alice has not joined us, so if any member has any questions, then send those to Madeline as written questions and Alice will reply in a written format. So we move on to the next item, which is public health KPIs. I believe Helen is joining us and we have Jyoti in the room. I don't know, Jyoti, do you want to kind of give us a high-level view of the report and any particular aspects you want to draw our attention to?
Yes, of course, I'll be happy to. So this is the first time I think you've received the public health KPIs, and I thank you for your interest in them. We have 9 overarching KPIs presented in the report, and there are 5 targeted or inequalities measures also reported on. Most of the measures that you see here are for Q3, and the reason for that is because most of them are derived from the Office of Health Improvement and Disparities Public Health Outcomes Framework. That's a mouthful, I know. So our partner organisations, OHID, produce these stats for us by and large, with the exception of 1 or 2. And that's why there's a bit of a lag in the reporting that you see. The vast majority of the KPIs are delivered through commissioned services, with the exception of the community wellness outreach offer, which is delivered in-house. As you'll see, there are a number of red and amber measures in there. Some of them have improved since Q2 and in fact have further improved since the last reporting in this particular report. And we do have a number of, most of them are green. We're not content with that. We want to, just because they're green, we don't want to just rest on our laurels. We also want to improve performance as far as we can continually for all of our measures. I think we have been concerned about the 0 to 5 measures. You will note the red, I think it's the only red overarching measure in the report, which is mothers who receive a first face-to-face antenatal contact. I would point out that this is not a national measure. This is a locally defined measure. We have set this measure ourselves. And we have set it based on the number of estimated births that we would expect in any given quarter, which we estimate to be about 400. We have been working closely, and Helen is online with us, with our provider, to understand why this measure is red and to improve performance of that measure, and likewise the new birth visit too. I'm happy to answer any questions that you might have.
Yeah, I think we should open it up to questions. members. Who's first? Alison, please.
Hello. I'd like to ask you about PH 8, where it says service users offered and tested for HIV, because I'm not quite clear who a service user is. And I know that at the Royal Berkshire Hospital NHS Foundation Trust AGM last week, Reading has a very high amount of late diagnosis of HIV, the highest in the South East, and there's a health van used there to engage, raise awareness, encourage testing and prevention. So obviously we're not as high as Reading. So if you could just explain what this KPI is telling us, as in what a service user is, and I wondered whether this van is used at all in Woking Borough, to reach parts of the community that might not consider the need for testing for HIV.
Coming on. The measure relates to people attending our sexual health service and who are judged by the service to be at risk of HIV, who are offered the... Yeah.
So what are we doing in Woking Borough to reach out beyond to people who perhaps need to consider?
I think it's an important question, and some areas do routinely offer HIV testing to anyone attending a hospital service. You do that in a more high-risk area, I guess, to reduce the risk of late diagnosis and to ensure that people get treatment. It's something we could consider, but the cost would need to be weighed up against the benefits, as well as the ethical issues concerned with doing that.
So would you happen to know what the rate of late diagnosis of HIV is in Woking?
I'm afraid I don't know off the top of my head. I could look it up and report back.
Thank you.
Okay.
This is my ignorance, I'm afraid. So these are performance, key performance indicators to do with the council's duties. But as I'm missing something, most of the services that these KPIs are concerned with are nothing that the council controls. Is that right? Are they all NHS provided?
That's not strictly true.
Okay.
We commission, so these services are commissioned by Public Health. Through the Public Health budget, we will set the service specification. We will monitor the contracts regularly with our providers. We just don't deliver them directly in-house.
Right, okay, thank you very much. So we estimate there's 400 people that should be receiving an invitation for an antenatal contact, and we're only managing 40. Is that, how much of that is a lack of staff availability within our people that we're commissioning?
Okay, I think there's a number of reasons for this, and I'll bring Helen in to give a bit more detail. This has been a journey, I think it's fair to say. We thought that it was due to a lack of notification of birth. So this is an issue between two services. So there's the midwifery service, which we do not commission. That's commissioned by the ICB, and the health visiting service that we do commission. The health visiting service needs to be notified of the births from the midwifery service. We have put in, what's the word? An electronic tool document to increase notifications, and that has improved. So since this quarter, we now have, how many, Helen? About 184 notifications?
Yes, 182 it was for quarter one. Yeah.
So that's improved, but there's clearly still a gap between 184 and 400. And on further investigation, there appears to be a particular issue for Woking midwives who have not yet been trained on how to upload the information. So that, I believe, is underway. I'll bring Helen in now to give a bit more information.
Yes, so it is underway. We're just checking that we do have the staff that are trained in RBH to be able to upload the information. We're also double checking our processes internally in Berkshire Healthcare to make sure the way that we are collecting the information is reliable so that we make sure there aren't any errors in the notification. And what we're looking for is that notification to be able to contact the families after 28 weeks of pregnancy. And what we do know is that we're seeing an increase in that number, but actually there's more work to be done. But also, you asked around staffing. It isn't anything to do with staffing. It's reliant on the actual notifications. But what I can then say to you is, once we receive that notification, the qualified health visitor will actually triage that notification, and they're looking for a set of risk factors for each parent to be. And if we feel that there are risk factors there, then we offer targeted support, and we would offer support in the home for that family. If we don't feel there are risk factors at that point in time, based on that information we've received, then those families are offered universal support, and that might be face-to-face or in a group. And what we do know is that the take-up isn't where we would want it to be, and that's something that we continue to explore as a service. So if I give you what I can, I don't know whether Madeline has got the flow diagram to share, or whether you want me to share it on the screen, Madeline, which
Can you share it, please?
Yes, of course I can. Just bear with me. So I'm hoping that you can see my second screen. So
we can see that fine.
Yeah, okay, so that you will see that in Q1 of 2025-26, we received 182 notifications. Now, every single one of those families will get information that goes out around health visiting service and advice and how they can contact us. And it also directs them to the Berkshire Healthcare website. And we have pages on that website that are around new births and what to expect from the health visiting service. And you can see there, from those 182, 26 of the parents, I'm going to take you to the left first of all, 26 of those parents to be were identified as needing targeted support. 19 of those parents were seen at home for a face-to-face visit, and 7 parents were not seen because they either didn't reply to the request or they refused the visit because it wasn't convenient for them at that point in time, because this isn't a mandatory visit. That doesn't mean that those families aren't then followed up, because they are followed up, and they will also be seen at the new birth visit, which we will talk about later on. So if we then take you to the right side, for all of those families that I said there were no risk factors, 156 of those parents to be were offered a universal contact. And you can see there that 19 parents chose to be seen face-to-face, 17 parents to be were seen for a group session, and 2 were seen in one of our children's centres in Wokingham. But 137 parents to be were not seen face-to-face. And that's the kind of thing that now we need to start looking at as to why. Now, it may well be because we work in partnership with our midwifery service, that actually they felt very well supported by the midwifery service. But actually what I can say to you is each of those families that don't pick up, that they don't actually access the service at this point, they're still contacted by the health visitor, and they're all given that information around how they can access the service. I'm hoping that helps you to see how we split it up more, but actually it also shows you that we still have some work to do, but I think the most important thing is that we're not getting all 400 or 300 as the target is of the notifications at this point in time, and we need to just check that that isn't process data driven, and then we need to explore it further if we find it isn't.
Questions? Rebecca, please.
It's kind of a comment really as well, an observation. I mean, one of the big concerns is that the inequality group it's got worse as well, and it's just, are people choosing to be missed? That's the problem. and they're not engaging. And, you know, the big concern is the parents that do then slip under the radar, that are not seen, and then the issues that come further down the line. And, you know, we're talking a lot about this early kind of help approach. And I know you're working on it, because I know we've talked about this, so I know you are working on it. When do you hope to start seeing this improve? And what will you do if you don't start seeing this improve? Because to be honest, if you look at it, the figures look pretty poor, to be honest. And there needs to be a really big push to get this up. And I know you are trying, and I know it's good that it's been identified. That's the most important thing. But when do you hope to see some improvement?
Within the next couple of months, we are, what in Berkshire Healthcare, one of the things that we do is we look at quality improvement, and we have a series of programs of work that we're addressing at the moment, which our commissioners in public health are aware of, because we're aware that we have high numbers of non-attendance. And actually we need to explore that, because at the moment we don't know the reasons. We could presume some of the reasons, but we don't actually know. And without asking our service users, then we can only presume what those reasons are. So one of the things we're doing is looking at non-attendance and exploring that. But we're also mapping with our commissioners. There's a piece of work that we're doing in Reading, and we will use the learning in Reading, which is to look at those families that don't access the checks, so the antenatal and maybe the new birth visit, and also then don't come to the 2.5-year check, because you would expect by then that any children that may be presenting with special educational needs, you would want them to have been picked up and referred appropriately if necessary. So we're looking to see, because at the moment we're thinking, are these the same families? But we don't know that. So we're digging deeper into the data to look at, are they the same families that are not attending all? Or is it that there's different populations that aren't attending? So what we know in Reading, for instance, is that we had thought that we were impacting different minorities within Reading. So again, we're doing a separate piece of work around non-attendance there, and the learning will come across into Wokingham and West Berkshire, so that we align our processes across. So I want to assure you really that we are looking at this, but we're following a quality improvement methodology so that we get the current state and we delve down into the actual root causes and listen to our service users as well.
Can I ask that these KPIs come back to Health Overview and Scrutiny again in the next, whenever that's possible, as in the next quarter, so in Q4, so we can actually look at them and see where they are, because just that concern.
Thank you. Yes, we will bring them regularly from henceforth. I just wanted to make a couple of other comments about that the antenatal visit. Others are counting a phone call as sufficient. We do think this is important, and we do want to pursue the face-to-face visits in the home for the targeted, but group for the non-targeted, because we think it's a really important contact point. I would also say, and Helen has confirmed this to me, that for those targeted families that they don't see, they don't just close them off. They do alert other health professionals, etc., to the fact that they haven't been seen. Thank you.
Any further questions? Mike?
I've got two completely separate questions, but I'll deal with the first one. Sorry, yeah. I've got two completely separate questions, but I'll deal with this one first. PH5 and PH6 seems to me the same thing. You've got people who are dropping out before 12 weeks, and you've got people who are completing it. But I don't quite understand. You've got 30% dropping out before 12 weeks, and you've got 35% achieving the role in the total number of people in treatment. Adults successfully completed is only 35%. Where's the other 25%? Sorry, PH5, you say you've got this is defined as people who've left treatment in an unplanned way before 12 weeks. Calculates the percentage of all those currently in treatment is 30%. So 30% are falling by the wayside. Yeah. I don't know how long the treatment is.
It's 12 weeks, I think.
Okay. Then, right, then your pH6 is the number of people successfully completing treatment. Well, it says in a rolling 12 months, it doesn't really say followed up. Because there's a bit here about following up offered 6-month aftercare. Yeah. So you've got 30% of the people falling by the wayside.
The national definition of successfully completing treatment refers to a person who has completed a course of treatment and who then does not re-present for treatment for a minimum of 6 months.
Yep.
This is calculated as a percentage of the total number of people in treatment for the rolling 12 months.
Okay, so 35% are not reappearing.
Yes.
30% are dropping out. What's happened to the other 35%?
They're still knocking around in the system. They're still being treated. Okay. They're in treatment.
I think it's apples and pears, isn't it? Because it's different time frames.
Yeah.
Yeah, well, that's what I was trying to understand.
Yeah.
Because it seemed to me that we're using the same data twice to produce 2 KPIs.
No, they're different measures. They're
that makes a difference. Thank you.
pH 5 is drug and alcohol, and pH 6 is just alcohol.
Thank you. My other question was, and maybe this isn't part of the duty of care, but diabetes type 2 is one of the biggest expenses to the health service and also one of the biggest killers, one way or another, and yet we don't have a KPI on how many people are being put on pre-diabetic or courses for pre-diabetics to try to get them to lifestyle, etc.
Okay, that measure would be with the health service. Our contribution to that is through the NHS Health Checks programme, where we would be, it's a low-risk programme where we call people who are aged between 45 and 70 to come mainly through our GP services to get an overall health check. Many of you may have experienced it yourself. You'll be asked about your diet, your alcohol consumption. You'll have your blood taken to check for cholesterol and blood glucose. So that would be our contribution to that. We're not reporting on that, and arguably we should. You're right.
Yeah, having been the lucky recipient of an invitation today for my annual health check.
Please do take it up.
But I will. And the last time I did, I ended up on one of these diabetic courses. And it's a long course covering 9 months. And the attrition rate is massive. We're down to about 6 or 7 people out of 30. Yeah, sure.
I would
Rochelle,
say,
please.
sorry, if you do want to scrutinise anyone, it would be the ICB. You could call in around that.
Rochelle, please.
Okay, I'm just wondering where he's getting these 35% from, because 5 and 6 here don't show any percentage points, at least on page 42. He's coming up with numbers, and I have no idea where he's getting it
They're on
from.
page 36.
Page 36, because that's the one we were looking at, was page 42 originally.
Subsequent pages.
Okay. 36.
Any further questions from anyone?
Yeah, I'd just like to go back to PH3 about the 2 to 2.5 year review and the target being 80%. Now in the definition it says that's based on a performance for the South East during 2022-23. I wondered if this would be revised, because I'd really like to see us aiming for a much higher target than 80%. It's such an important thing to be doing with 2 and 2.5 year review. It's a long time since my children were that small, so I also just wanted to ask, the majority of mothers are in full-time work these days, so how is this enabled? Are there appointments after work time or at weekends, or do parents have to take time off to have this appointment?
I agree with your points, and perhaps we could challenge ourselves more on that. I'll bring Helen in around the detail.
Yes, we are performing, when we compare to others, we are performing well in Berkshire as a whole. What I would say to you is we do offer variable clinic times, so absolutely we have to offer clinics when it makes sense for the families, but also for the children, because obviously at 2.5 it needs to be at a time where we're going to get the best from that child as well. But we do have variable appointments. Again, this appointment isn't mandatory, but what we are trying to do, there's a series of work happening at the moment with our early years colleagues as well, to look at how we work together for these 2.5-year checks, because actually working in partnership is actually going to encourage, and all of us have got parts of the information, and actually coming together and working in an integrated way for those families perhaps that we're missing is something that we want to move towards. But I think it's right to pick it up. We're not where we want to be yet, but I have to say we have improved significantly from where we were.
Anybody else? Sorry, can you?
Chairman, I just wanted to make a quick point, which I think you might appreciate, that we weren't able to be told how many deaths of Woking residents because they died in hospitals. But we have been told how many children were born in Woking Borough, whereas I assume an awful lot of those 1,600 babies were actually born in the RBH or Frimley.
A point taken. Any further questions? Because I think we're getting to the end of this item. Firstly, thank you very much, Helen, Jyoti.
My pleasure.
Really appreciate you coming in and presenting. Obviously, we know it's a work in progress. Some of these numbers are very disappointing, and we obviously want to see a better direction of travel in the future. One very small point, when we're chasing people down, if I look on page 44, service narrative, in Q3, it said sometimes when people have not been seen, one of the reasons is babies in hospital. I would have thought if the baby's in hospital, you know where it is. Surely you should go and visit it. I can't see why that's a reason not to visit a baby.
Sorry, David, sorry to interrupt, but they stay under the care of the midwife. So while they're in hospital, they're still under the duty of care of the midwife. So that doesn't mean that we won't visit. What we do is we wait till they come out of hospital and that care, and we will then go and visit. So what we aim to do is we aim to visit by, and most of the babies are then visited by day 21. I have to say a huge number are visited by day 15 if they're not seen, because we aim to go between day 10 and day 14. But there may be complications, or it may not be appropriate to go into the hospital. So they stay with the midwife. The minute we know that they've been discharged, then we would do the new birth visit.
Thank you very much for that answer. Thank you very much. Look forward to seeing you again. Thank you, Ellen.
Okay,
thank you, Jyoti.
Thank you. Bye-bye.
Bye-bye. Now, what have we got left? Over to the boss.
So forward programme, we've got quite a lot of items. We've tried to schedule the majority of the items that were on the unscheduled list. We haven't quite got them all there yet. And you'll see there's still a few on the currently unscheduled, either waiting because it's in a new municipal year, some suggested as a briefing, and some are just are waiting to be scheduled. We do have one additional item suggested for the committee as the most appropriate scrutiny committee, the update on Marmot as well. So that's just something to be scheduled as well. Does anyone have any comments about any of the items, particularly for the November meeting?
After what the coroner said today, I definitely want them back in the next 6 months or 9 months or something like that. because we need to see some progress on this charging families when they've just had somebody die in tragic circumstances, which I think is ridiculous, frankly.
Any other comments? Or what I should say is obviously the items are dependent on officer availability, so that is our hoped forward programme. Sorry, Councillor Shepherd-Bay.
What can we do to save these families who are being charged for this?
I need to take that point offline with you. Okay. But if that's it, thank you very much, everyone. Good night, and God. Oh, sorry, Mike.
One suggestion. We're looking at a significant increase in housing over the next 10 to 15 years in the borough, particularly if we've got to comply with the Labour's build programme. I would be interested to know, from a strategic point of view, how healthcare provision is going to keep up with that increase in housing.
I've been asking that question for 6, 7 years. I never got a straight answer. What we should do, in theory, the ICB is talking to our planning department about our new plan. And the proposal that was made by Ingrid 2 years ago was that we have an offline session with the ICB and the planning team. That was a suggestion from Ingrid, and I thought that was a jolly good suggestion, because obviously there will be confidentiality reasons why we would not want that in a normal HOST meeting. So I would be very happy to have that meeting with our planning department and with the ICB to confirm number of GP surgeries, number of dental practices, etc., 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 which I think is going to be critical to the future. Alison.
Could I just ask that we have on the programme looking at the public health KPIs again, because it's not mentioned for the rest of the year?
I think they're down for January, but if obviously it's more appropriate, Jyoti will advise if it needs to go to November.
Oh, yeah, it's hiding at the top. But just in January?
We can schedule them as appropriate.
We're not going to, when we look at Q3 ASS, we're not going to look at the PH ones as well? Couldn't we?
I'll look at which ones are available and update members.
Thank you.
Adrian, could I be invited if you have that off?
Yeah, of course.
Because I think that would be useful for me to know as well, because I haven't found, I've been trying to find this kind of thing out, and there is a stone wall. Yeah,
I mean, you know, I've asked that question directly to the ICB many times, and the chair gets a bit sweaty and nothing happens. I'll close the meeting. Thank you very much, everyone. I wish you a good night.